The Lake Superior Shingles, what providers should know. Your host for today, Michelle Dewey, will begin.
Thank you, and good afternoon, everyone, and welcome to today's webinar presented by the Lake Superior Quality Innovation Network. Lake Superior Quinn is comprised of 3 organizations, MPRO in Michigan, Metastar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective states. Today's webinar slides will be available on our Lake Superior Quinn YouTube page within the next week. I would like to introduce you today to our speaker, Dr. John Tempte. Dr. John Tempte pursued his medical training at the University of Wisconsin-Madison Medical School, receiving his MD in 1987. He is a 1993 graduate of the University of Wisconsin-Madison Family Practice Residency, where he stayed on as faculty, achieving the rank of professor. He teaches family practice residents and practices full-spectrum primary care medicine to an underserved and highly diverse community at Wingrove Family Medical Center in Madison, Wisconsin. Dr. Tempte currently chairs the Wisconsin Council on Immunization Practices. He served as a voting member of the U.S. Advisory Committee on Immunization Practices from 2008 to 2015 and became the first family physician to serve as chair from 2012 to 2015. John has participated on pandemic influenza and bioterrorism working groups for the state of Wisconsin. He is the principal investigator of the Wisconsin Influenza Incidence Surveillance Project, the Oregon Child Absenteeism Due to Respiratory Disease Study, and the Rapid Assessment of and Prophylaxis of Influenza in Dwellers of Long-Term Care Facilities Project. His current research interests include viral disease surveillance in primary care and communities, seasonality and epidemiology of influenza, and attitudes toward immunization. So at this time, I would like to turn it over to Dr. Tempte.
Thank you very much, Michelle. I really appreciate the introduction and the opportunity to speak to everyone today on shingles vaccine. This is an interesting topic for me because the new shingles vaccine, as we all know, is in very short supply. And I have to give the disclaimer that I will be talking about a vaccine that I have yet to administer to anyone because our health system has had none. But that being the case, I think it's a very good time to review shingles and the disease underlying shingles, provide a good comparison of the 2 existing vaccines, one Zostavax, which has been in existence for more than a decade, and the new vaccine, Shingrix. I also will try and provide a little information about insurance coverage for these vaccines, provide the current recommendations from the U.S. Advisory Committee on Immunization Practices on adult vaccines in general, provide some ideas on how we can improve adult vaccine coverage, and then we will have some resources to share as well. There will also be some time at the end of this presentation for questions and answers. So shingles is a relatively common affliction, particularly in older individuals. This is a condition caused by reactivation of the varicella zoster virus that exists within neurons of people. Most of the people on this call, I would assume, acquired chickenpox in childhood. I remember I had a tremendous case when I was 18 and lost 2 weeks of high school because of that. But the chickenpox virus, or varicella zoster, will remain latent in neuronal cells for long periods of time and then can reactivate, causing shingles. The primary infection is a very contagious disease, chickenpox, which is typically spread as a respiratory modality through droplets. But again, the reactivation causes shingles. And whereas this can occur virtually at any time in life, there is a significant increase with older ages. For those of us in primary care practice, we can say that we've seen shingles in children, young adults, older adults, and particularly most commonly in the elderly. The symptoms characteristically are going to be significant pain, itching, and burning, typically in a dermatome pattern. By dermatome, I'm talking about an area that is innervated by one of the spinal nerves. So typically, we will see individuals complaining about burning or itching, sometimes throbbing and stabbing localized pain in a circumscribed area. And this can occur days, sometimes even weeks before the appearance of a rash. Because of the vaccine or the chickenpox vaccine, we see less and less chickenpox disease in our practice. I am in a residency training clinic, and unfortunately, I rarely ever have the chance to show my residents chickenpox anymore because of an effective vaccine. But when shingles comes out, it occurs as a vesicular, macular, papular rash, which is reminiscent of a large patch of what I would have considered chickenpox-type lesions in the past. And again, these occur along nerve pathways. They are almost always unilateral, more commonly found in the trunk or face. And the lesions undergo an evolution from emerging from a reddish rash to vesicles that are scabbed over and then clear up in a matter of 2 to 4 weeks. Accompanying this rash can be fever, headache, photophobia, and nausea. The complications can be many, but the most common and most notable is something called post-herpetic neuralgia. This is mild to severe pain in the area over which the shingles rash occurred. And I have to emphasize this can be excruciatingly painful. I have taken care of some adults who have had significant changes in the quality of their life. Studies have indicated that the pain with post-herpetic neuralgia can be worse than childbirth, can be worse than severe chronic low back pain, and can be unremitting. Again, this can have significant impacts on quality of life. The pain can be constant or intermittent, and unfortunately can persist from weeks to months and even to years. If we look at some of the additional ramifications, there can be sleep disruption, work disruption, and definitely impacts on mood, particularly with the occurrence of depression. Activities of daily living can be impaired, and quite often we find that this can lead to social withdrawal. Interestingly, this is more common in Caucasian and African American patients. And again, as mentioned previously, there really is an age relationship that goes on. Keep in mind, again, the severe pain, the extensive rash, and trigeminal location are all factors that can increase the severity. Another complication occurs when the dermatome overlies the eye. 15% of shingle cases can result in herpes zoster ophthalmicus, and this is of concern because if untreated, it can result in visual impairment or even blindness. This, for me, is an immediate referral to ophthalmology for evaluation and treatment. Other neurological complications can include myelitis, so inflammation of the spinal cord, encephalitis, meningoencephalitis, ventriculitis, cranial nerve palsies, and ischemic stroke. There can be viremia of the varicella zoster virus, and one can potentially see cutaneous dissemination looking somewhat like chickenpox again, pneumonia, hepatitis, and even disseminated intravascular coagulation, although these findings are quite rare. There can be secondary rash infections from the initial, so thinking about the staph and strep secondary infections, and this can result in permanent scarring and changes in pigmentation. So who is at risk of getting shingles? Well, many of us are. It turns out that almost 1 out of every 3 Americans will develop shingles in a lifetime. This is my opportunity to remind everybody that the American population is rapidly aging, and every day approximately 11,000 Americans enter the Medicare population for age 65. We estimate over 1 million cases of shingles per year. And again, anyone who has ever had chickenpox disease or the varicella vaccine can develop shingles. However, I'll caution people in that second area, we really do not have a good understanding of where individuals vaccinated with the varicella vaccine will be on the spectrum in the future. 2 other points that are important to bring out is the fact that for younger individuals receiving the chickenpox vaccine, we do see less shingles, number 1. Number 2, for older adults over the age of 65, we're seeing a slight decline in shingles, likely due to the use of the shingles vaccine. But we're seeing increasing rates in the unvaccinated population between the ages
Someone has entered the conference.
Between the ages of 20 and 65. And we think part of this might be due to the lack of circulating wild-type chickenpox that serves as a booster of the immune system. So the risk for shingles will increase as immunity declines. We know definitely age is a predictor of reduced immunity. The whole area of stress is controversial. There have now been some good studies looking at situational stress, for example, the death of a spouse, and finding no relationship with the onset of shingles. But definitely medical conditions in which the immune system is suppressed can lead to reemergence of VZV, and also immunosuppressive medications such as steroids, chemotherapy, and transplant. I also have to point out that at any given time in our population, roughly 10 million Americans are receiving immunosuppressive drugs. Switching focus now to the vaccines, we now have two options available. The first vaccine was called Zostavax, and it is a live attenuated virus. It comes from the OKA strain of varicella zoster, and it is exactly the same virus that's used in the childhood varicella vaccine. The recommendation for this is a single subcutaneous dose. Coming to the stage this past October with the recommendation from the Advisory Committee on Immunization Practices is the new one called Shingrix. And unlike the live attenuated, this is a recombinant vaccine. A subunit of the varicella zoster virus has been taken and placed into cell culture, producing copies just of the subunit. This is also a vaccine with an adjuvant, and adjuvants, as a reminder, are chemicals that activate the immune system and help to create an immune response to a given antigen. Shingrix has a 2-dose schedule. The first dose is provided intramuscularly, and this is followed in 2 to 6 months by the second dose. Going back, there is no indication at this time for any repeat dose of Zostavax, and there is no indication for a third or booster dose of Shingrix. Now, if we go back and look at the initial studies done for Zostavax, we find that the vaccine had less initial effectiveness with older people. So in this slide, patients or subjects receiving the vaccine who were between 60 and 69 years old had about a 65% initial vaccine effectiveness. For those over 70, it dropped down to almost half of that. The other thing is that with time, immunity to the initial Zostavax declined. So by approximately 8 years after immunization, most subjects returned to baseline and had virtually no protection. The new kid on the block, the Shingrix vaccine, has a much higher initial vaccine efficacy. And this efficacy is high not only for individuals age 50 to 59, but also for 60 to 69, and even for those patients over 70 years of age. If you look at the blue dotted lines on this graph, that's the equivalent efficacy noted with the Zostavax. So this new vaccine has a much higher initial protection. We do not know at this point in time how durable this is going to be, but the initial studies have been quite favorable. The routes of administration are as follows. Zostavax is a sub-Q dose, 0.65 milliliters, and it has to be administered immediately after reconstitution to minimize loss of potency. If not used within 30 minutes, it should be discarded. Shingrix is an intramuscular administration, 0.5 milliliters. And again, it should be administered immediately after reconstitution or can be stored in the refrigerator for up to 6 hours. And keep in mind, this again is a 2-dose series. For storage, Zostavax is a powder in a vial and has to be kept in a freezer. The diluent is kept at room temperature. The diluent should not be frozen. On the other hand, Shingrix is refrigerated and it should not be frozen. If the vaccine is frozen, it needs to be discarded. So I bring this up because making a change from one vaccine to the other can lead to administration and storage issues and problems. Even worse if a clinic has both vaccines at the same time, and this can lead to a lot of error potentially from the vaccine providers. Side effects are as follows. With Zostavax, there can be injection site reactions, and in rare cases can be a disseminated chickenpox-like rash. Herpes zoster can occur in those patients with immunocompromise, and this can be actually quite severe in some individuals. Accordingly, this live attenuated vaccine is not recommended or is contraindicated for patients with immunocompromising conditions. We have less knowledge of Shingrix as a new vaccine, but because of the adjuvant, there certainly can be some significant arm pain with the intramuscular injection. Also, there can be redness and swelling. And 1 out of 6 individuals had grade 3 side effects, preventing them from regular activities for 2 to 3 days. So those are more severe side effects. Side effects were more common with younger patients, and patients can have side effects with either the first or second dose. The Vaccine Adverse Event Reporting System, or VAERS, received 155 reports of Shingrix during the first 4 months. And again, going back to the previous slides, 8% were administration errors. Inappropriate age, the wrong vaccine information, frozen vaccine given to the patient, and so on. So just be very, very careful to adhere to the package insert for administration and storage. A quick plug for the VAERS system. This is accessible by any clinician or by any individual who wants to report. It's a passive system, but an important component of our vaccine safety system. Any administration errors can be reported to the Vaccine Error Reporting Program through the URL shown below. So the current recommendation from ACIP is for shingles can be provided for the prevention of zoster and its complication. And this is for immunocompetent adults age 50 and older. So 10 years younger than with Zostavax. Also, anybody who previously received Zostavax is eligible to receive Shingrix. There is no specified interval between these two, but for patients that I'm counseling now who are coming to my practice asking whether or not they should receive the new vaccine, I typically say that if you've gotten Zostavax within the past 4 or 5 years, you do have some coverage. If it's been more than 8 to 10 years, definitely you should be looking at this new vaccine. But we don't have any firm guidance for that first or the interval between Zostavax and Shingrix. ACIP also made a preferential recommendation for Shingrix over Zostavax. This is not a very common occurrence for the Advisory Committee on Immunization Practices, but was based on the fact that the efficacy estimates were significantly higher and the rate of waning was lower than with Zostavax. One of the big problems right now with a new vaccine that has a preferential recommendation for a target audience of several tens of millions of people, we end up with shortage. So if your office does not stock the vaccine, you can still give a strong recommendation, but refer that patient to pharmacies, to local health departments, or to other medical facilities. However, I'll give a caution. I just talked to a patient yesterday who said that they were on a waiting list at the national pharmacy that they go to. So this shortage is hitting everybody across the country. As far as insurance coverage, neither of the shingles vaccines are covered under Part B of Medicare. This includes only influenza vaccines, pneumococcal vaccines, tetanus-containing vaccines used for treatment of a wound, and hepatitis B vaccines in some cases. So patients have to rely on their Part D coverage, which can be all over the map for patients. So there can definitely be a co-payment for the patient depending on which Part D plan they have. Medicaid may or may not cover the vaccine, and private insurance are generally covering the vaccine, but it depends. But I'll also mention that for individuals covered by insurance up to the age of 65, any ACIP recommended vaccine has to be covered by the insurer under the Affordable Care Act. But unfortunately, that does not apply to patients over the age of 65. Billing codes, I will just put up here for your reference, and these slides can be obtained off the website in the future. I'm going to move along a little bit just in terms of the whole area of adult vaccines in general. And again, we have a population that is rapidly aging, and we have several vaccines that are indicated for all adults. So we're right at the beginning of the influenza vaccination season, and so there's a strong recommendation for everybody over the age of 6 months to receive influenza vaccine. All adults should receive 1 dose of Tdap, and then there's a every 10-year TD recommendation routinely. The only exception for repeat Tdap for tetanus, diphtheria, and acellular pertussis is for every woman during pregnancy between 27 and 36 weeks of gestation. And this provides protection for the newborn over the first 4 to 6 months of life. MMR is recommended for adults who were born after 1957. So if adults have not received 2 doses of MMR-containing vaccine, that's a strong recommendation. And again, remember for those younger adults, 2 doses of varicella-containing vaccine are indicated. When we come to the new vaccines, RZV and ZVL are the abbreviations used on the table for the recombinant zoster vaccine and the zoster vaccine live. The Shingrix, or the recombinant, again, is recommended starting at age 50, or the Zostavax is recommended starting at age 60. This slide just covers the recommendations I provided and also includes the MenACWY, that's the meningococcal quadrivalent vaccine. And I mention this particularly for some high-risk groups out there. Individuals who are asplenic or are at risk because of the work need to receive the vaccine and then booster every 5 years. One group of patients we oftentimes forget are patients with sickle cell anemia. In terms of changes in the schedule, I've already covered this for the most part, but again, keep in mind, for patients under the age of 60, there's only one choice for zoster vaccine, and that's Shingrix. Over the age of 60, or for 60 and above, either vaccine can be used, but ACIP expresses a preference for Shingrix. In the last few minutes here, I just want to talk a little bit about improving vaccine coverage for our adults. This is always an area that we are lacking on. Most states, and particularly Minnesota, Wisconsin, and Michigan, do very well with childhood vaccine coverage. But all of us fall short on adults. In 2013, the National Vaccine Advisory Committee provided the standards for adult immunization practice. And this was published in the following report from Public Health Reports. And I'm just going to cover the highlights here very quickly. There are 4 main recommendations. The first is to assess immunization status for each and every one of your patients at every clinical encounter. We want providers to stay informed of the latest CDC recommendations and ACIP recommendations for adult immunization. In practices, it's important to implement protocols and policies to ensure that patients' vaccines are reviewed and met at every visit. This doesn't mean that the physician has to do this. There are several people within any clinical practice that can provide this service. I'm giving you an example of one of my patients here, and in my electronic record, one of the hot buttons I have down on the left side of the screen is for the Wisconsin Immunization Registry. There's a hot link there that takes me directly to the registry for this patient, and in a quick glance, I can look down at the bottom part that gives the forecasting and lets me know what vaccines are needed to complete this patient series. The upper screen provides me the record of vaccines. Both Minnesota and Michigan also have functional immunization registries. The other thing I'll mention is patients do much, much better when they have a medical home. A medical home is associated with a 10 to 40% increase in immunization rates, even when vaccines are universally covered. And coverage rates are much better for generalist clinicians than for specialty clinicians. The second standard is to strongly recommend vaccines that patients need, again, at every visit. You want to provide tailored reasons why the vaccine is correct for that patient, highlight positive experiences, address questions as they arise, remind patients that the vaccine not only protects them, but also protects their loved ones. And especially with older individuals, it's important to look at the full cost of getting sick. So often in my practice, I see patients who are caregivers for a spouse with dementia, a spouse with significant medical problems, and if we have somebody, for example, hospitalized with a vaccine-preventable illness, there are larger consequences than just that individual patient. One of the available resources is this fact book from the American Academy of Microbiology. This came out a few years ago, but was written at a patient level and is available as a free download. There are other wonderful patient educational tools, and this is available on the Lake Superior Quality Innovation Network website. So I direct you to look for this in terms of information for flu, tetanus, pneumococcal pneumonia, shingles, and additional vaccines. The third standard is to administer the needed vaccines at your practice or refer patients to another vaccine provider. Offer vaccines that you stock, refer patients to providers for those vaccines that you don't stock. There are many things out there that have been shown to be quite effective in improving rates. The community guide for public health interventions provides us a lot of information. So enhancing access to vaccine services such as home visits, reducing costs, having school-based programs and WIC-based programs are all effective. Also, it's important to increase demand. There can be recipient incentives, patient reminders and recalls, and also school mandates. Provider system-based interventions include immunization information systems, for example, within the electronic health record, assessment and feedback, reminders to providers, standing orders, and combinations. The reminder systems identify patients for whom vaccines are needed. Recall systems identify those patients who are overdue. This method has been shown to be about effective with a 17% increase in coverage rates when used by itself. Assessment and feedback has strong evidence of effectiveness with a 16% increase in vaccine coverage when used alone. This provides assessment of a practice's or an individual's coverage rates and provides this information back to the providers and does a nice job of incentivizing the provider to improve. Standing orders are wonderful. This is probably the strongest intervention and allows other people within clinical practices to provide vaccines. So non-physicians can deliver the vaccines under a protocol, and this can be used in many different settings. There are some nice forms from the Immunization Action Coalition with the website up at the top here for standing orders in your practice. The other thing is we need to embrace our partners in other locations, particularly in pharmacies, that most clinics don't have the same hours of availability that pharmacies do, and pharmacies are often available on a walk-in basis. So keep in mind it's important to address and embrace our partners in pharmacies. One important consideration, however, is the pharmacies really need to be involved with their state registry. Other interventions that can increase coverage in elders in the community are nurse visits or pharmacists providing education, phone calls from other seniors, a telephone invitation for a vaccine, nurses educating in vaccine, providing free vaccine, and having patient group visits. All have been shown to be effective. So the last standard is documentation. And again, put a big plug-in for the state immunization registry. These help your office keep track of who needs vaccine. It allows follow-up to occur. And also, if you have patients that are vaccinated elsewhere, doing follow-up through that registry, and sometimes even having to enter that data is going to be an important component. I've practiced my entire career in Wisconsin, and we have a real gem here called the Wisconsin Immunization Registry. This registry is the backbone for most other states' registries, and this is something that I use for all my clinical sessions and virtually use on every one of my patients. It provides good, accurate, and up-to-date information. And unlike proprietary electronic health records, this contains vaccines provided by anyone across the state. What we hope for is for the barriers between states to slowly come on down and to have more sharing across state lines, particularly for those individuals who are living in one state but receiving medical care across the border. Final slide here, just showing some of the resources out there from CDC, the Immunization Action Coalition, Michigan Department of Health and Human Services, Michigan Care Improvement Registry, and contact information here. And I think with that, I will be quiet and ask the operator to open the lines for any questions. I thank you for your attention and wish you good immunization coming up this fall.
Operator, could we open the lines for Q&A? And WebEx, if you could pull up the evaluation at this time.
Ladies and gentlemen, if there are any questions, please press 1 on your keypad. If you have any questions, please press 1 on your keypad. Our first question comes from Gloria Melvin.
Yes, will this presentation be archived so it can be viewed at a later date?
I'm going to defer that to Michelle Dewey.
Yes, this is Michelle. The slides will be posted to our Lake Superior YouTube page within the next week.
And how could we obtain a copy of the slides and the comments?
Michelle, can you answer that as well?
Sorry about that. I was on mute still. Jessica, is there a way we can get them the paper slides before we post it on the Lake Superior YouTube page?
Sure. If you want to put your email address in the chat box, we can make sure we get a copy of those slides to you.
Thanks.
Any other questions?
There are no further questions in queue as of this time.
Well, again, I would thank everybody for their attention, and I'm also very open to any direct questions. If you want to send me an email, the best way is, let me give you my email address. It's jon.cem, as in Mike, CE, at FAMMed, S as in Frank, AMMED, .wisc, WISC, .edu.
Thank you, Dr. Tempe. You gave a great information about the shingles vaccine, the difference between the two, and an overview of the disease. So I really appreciate you taking the time out of your day. I know you're busy, and I hope everyone learned something today. And again, the slides will be on our Lake Superior Quinn YouTube page within the next week. And please take a moment to fill out the evaluation. We do appreciate your feedback. And again, thank you, Dr. Tempe.
Very welcome. Take care now.
You too.
Ladies and gentlemen, this concludes the conference for today. You may all disconnect.